So in our part of the world, we see a lot of polypoidal choroidal vasculopathy because we do routine ICGA in every case that comes in with exudative AMD. So we pick up about 50% at least, if sometimes even more, of cases actually having polypoidal choroidal vasculopathy. I understand that in many parts of the world that is not routine, and particularly because the prevalence of PCV is much lower. Some reported study ranging from maybe 5% up to about 20% in white population. So I understand it can be a little bit challenging to diagnose PCV in these populations. So a few clinical clues which I find very helpful are, first of all, the demographics. Of course, if you've got a patient from Oriental races, perhaps a male predominance, that tends to be more common to present with PCV. In terms of the clinical picture, a presence of hemorrhagic appearance and large PEDs are also factors which are quite common. We see about 50% of these cases turn out to have PCV in our population. So before going to ICGA, a very useful test to do is OCT. On OCT, there are several features which are very, very helpful. Of course, a PED, either a large PED or sometimes a narrow PED, or some people coin the term a peaked PED or a thumb-like protrusion of a PED. Sometimes within the PED at the apex, you may even see a hyporeflective circular lesion, and that is likely where the polyp actually resides. In addition to the PED, often we will see an area with an undulating RPE, where there is separation of the RPE line from the Brooks membrane line. We call this the double layer sign, and it's usually where we can find the branching vascular network when we correlate with the ICGA. Another feature which is useful is to look for thick choroid or very large prominent outer choroidal vessels. So as we know that PCV now resides within the pachychoroid spectrum. So that's also another clue that makes us or alert us to the possibility of polypoidals, and therefore if you don't do ICGA routinely, I would highly recommend to look for to do an ICGA in these patients. Now that is for the first presentation. Of course, I can't overemphasize the importance of thinking about PCV in patients who you feel is not responding adequately to anti-VEGF monotherapy. So in the past with anti-VEGF therapy trials, it has been suggested that some patients with PCV may not respond so well to monotherapy. For example, in the average trial, it suggests that with ranibizumab, if you combine with PDT to ranibizumab, there is a better response. But in the PLANET study, PDT was only used in the mode of a rescue therapy. So it was very reassuring to say that if you treat the patient with 3 loading doses followed by fixed 8-weekly dosing, you can actually achieve very good visual outcome, over 10 letters improvement, and only 15% of those cases actually met the rescue criteria from that study. So that is reassuring, but also to remind us that even if you're treating with anti-VEGF monotherapy, there is always a small proportion of patients, if you suspect is not responding adequately, think PCV, check the ICGA, and revise your diagnosis and treatment plan. Thank you very much.